Threatened abortion, a condition in early pregnancy characterized by the vaginal bleeding without the cervical dilation or the expulsion of the fetus. Gestation age usually occurs between the 20 weeks of the gestation. Etiology: chromosomal abnormalities. Most common cause: maternal factors like infection, uncontrolled diabetes, thyroid disorders, antiphospholipid syndrome, uterine abnormalities. Fibroids, septate uterus, cervical incompetence. Lifestyle factors like smoking, alcohol, drug use, trauma or the stress. Clinical features like the vaginal bleeding are mild to moderate. Closed cervical was distinguished from the inevitable abortion. No passage of the fetal tissue. Mild lower abdominal pain or the cramping. Fetal heart activity may be present. Diagnosis: clinical examination, closed cervix with a vaginal bleeding. Ultrasound, fetal heartbeat present. Better prognosis. Subchronic hemorrhage may be seen. Serum BHCG. Serial measurements to assess the viability. Progesterone level. Low levels indicate the poor prognosis. Differential diagnosis like ectopic pregnancy, implantation bleeding, inevitable, incomplete or the mixed abortion. Management: observation. Many cases resolve spontaneously. Bed rest and the pelvic rest, no intercourse or the strenuous activity. Progesterone therapy if low progesterone is suspected. Treatment of the underlying conditions like infection control, managing chronic disease. Rh immunoglobulin given if the mother is Rh negative. Follow up: repeat ultrasound and BHCG monitoring. Pregnancy: 50% of the cases progress to the normal pregnancy. Risk of miscarriage increases with the heavy bleeding, large subchronic hemorrhage or declining beta HCG. No increased risk of the fetal abnormalities in the continued pregnancy. Threatened abortion presents with the vaginal bleeding but a closed cervical OSA occurs before the 20 weeks of the gestation. Most common cause is the chromosomal abnormalities. Other risk factors include the maternal infection, diabetes, and the uterine abnormalities. Ultrasound is a primary diagnostic tool. Presence of fetal heartbeat suggests a better prognosis. Serial beta HCG and the progesterone level help assess the pregnancy viability. Bed rest and the avoidance of the strenuous activity are recommended. Progesterone therapy may be considered if levels are low. Rh negative mother requires the Rh immunoglobulin to prevent the isoimmunization. 50% of cases result in the normal pregnancy. The rest may progress to miscarriage.